Welcome back, friends. Well, we are going to talk about calcium channel blockers. We have already discussed JNC7, JNC8, and now we are coming on to the calcium channel blockers, what role they need to have to play when they control blood pressure, that is high blood pressure or hypertension. We have already discussed about the antihypertensive efficacy of the drugs. We have also discussed about the ways in which a blood pressure can be monitored. Either it can be in clinic measurement of blood pressure or it can be an ambulatory blood pressure monitoring. So now let's go on to calcium channel blockers, and probably we'll be talking about Amlodipine later. So let's move ahead. So first we need to know what types of channels are there. Well, these are voltage sensitive channels. They are of three types: L, T and N. Well, L type of calcium channels, they are found in your cardiac muscle, smooth muscle, sinoatrial node, atrioventricular node. Then the T type of calcium channels, they are located in the SA node, central nervous system and the endocrine system. Well, the third type of voltage sensitive calcium channels are the LN type. Well, they are present in your central nervous system. Only the L type of channels are blocked by amlodipine. AML stands for amlodipine. Now on the next slide you can see the classification of calcium channel blockers. They can be either selective DHPs or they can be non-selective DHPs. Well, amlodipine belongs to selective DHP, that is the dihydropyridine calcium channel blocker, and it blocks only the vascular smooth muscles, whereas the non-selective DHPs, they are present in your myocardium and in your vasculature. Well, according to the half-life, the calcium channel blockers can be further classified into inherently long-acting and short-acting calcium channel blockers. Now we go on to the next slide, which talks about the types of channels. Well, we have already spoken about it. Now I'll show you a representation in the slide so that it's always you can remember and always do a recap when you are trying to express yourself. Well, the L type, which are seen mostly in your cardiac muscle, this is a cross section of the heart. Then the T type, they are found in the brain as well as in the heart, and the N type, they are predominantly found in your central nervous system. Now again a recap of it. So what is the effect of the L channel stimulation? Well, on the heart, well, they increase the force and the rate of contraction, which increases the workload. Secondary, in the coronaries, they cause coronary, you can say, vasoconstriction, which leads to a reduced blood supply to the heart. Well, in the peripheral blood vessels, there is vasoconstriction, and which will increase the afterload on the heart. So these are the three effects, you can say, to summarize when the L channels are stimulated. Well, in the heart, we'll again do a recap. They increase the force and the rate of contraction, which increases the workload. In the coronaries, they reduce the diameter, or they reduce the lumen of the coronary vessels. Once the lumen of the coronary vessels is reduced, the blood supply to the heart muscles will be reduced too. In the peripheral blood vessels, they again cause vasoconstriction, which means it reduces it narrows the lumen of the peripheral blood vessels, which causes an increase in the afterload. Well, in the sinoatrium and the AV nodes, they increase the activity. Well, these all will increase your blood pressure, so there will be an increase in the oxygen demand and supply ratio. What will happen if these L channels are blocked? Well, in the coronaries, they will cause vasodilation, which will increase the blood supply to the heart. Well, they cause peripheral vasodilation, which means it increases now the lumen of the heart and reduces the afterload. Sorry, it increases the lumen of your vessel. So it reduces the afterload on the heart. Now it impairs the sinoatrial and the AV conduction. Then there will be a decreased force and rate of contraction of the heart muscles. Simultaneously, it will lead to a decrease in the blood pressure and decrease in oxygen demand and supply ratio. So when you are giving an amlodipine or maybe other selective dihydropyridine. I'm going to talk just about the selective dihydropyridine calcium channel blockers. Then this is basically what is happening all across the receptors, well, in the coronaries, in your peripheral vessels, in your heart muscles, what is happening with the conduction of the impulses and with the force and the rate of contraction, and how the blood pressure falls, and how there is a decrease in the demand and supply for oxygen. So these are the effects which are later deployed when we talk about amlodipine. So let's go on to the next slide. Well, these are once we spoken about the blockade, we've spoken about the stimulation, then we should also know what are the adverse effects due to non-selective blockade. Well, as we have already discussed, well, it impairs the SA and AB conduction, then it decreases the force and the rate of contraction, it causes bradycardia, that is reduced heart rate, then it causes atrioventricular block and maybe other conduction abnormalities. There is a term called as reflex tachycardia, which is commonly seen with non-selective blockade. Well, it is palpitations, that is increase in the heart rate due to the sudden fall in the blood pressure, and this leads to the baroreceptor mediated tachycardia. So there is a fall in the blood pressure which leads to the baroreceptors getting activated. They cause an increase in the heart rate in order to balance the fall in the blood pressure, or in order to bring the blood pressure back to normal or towards the higher side. So these are the adverse effects which are commonly encountered when you are giving non-selective calcium channel blockers. So reflex tachycardia is the term. It is palpitation due to sudden fall in blood pressure, which is due to activity or stimulation of the baroreceptors, and which will lead to increase in the heart rate, and finally the outcome is increase in your blood pressure. So let us revise. Well, L-type voltage sensitive channels are responsible for contraction of cardiac muscles or the myocytes and the vascular smooth muscles. Then there are different L-type channels. They are called the subtypes. They are present on the heart and on vessels, including the coronary arteries. Well, non-selective blockade of L channels runs the risk of bradycardia, AV block, and other conduction abnormalities. Agents are available that selective block only the vascular channels, and they are called as dihydropyridine calcium channel blockers. So what are the unique features of amlodipine? Well, we are going to talk about its first the physiochemical properties. Well, it ionizes at physiological pH. It has got a high lipophilicity, which causes an increase in the membrane course concentrations, which leads to a sustained reservoir of amlodipine in your body. Sustained reservoir for binding over time to calcium channel receptors. So due to longer half-life and due to a sustained reservoir, there is a slow onset and longer duration of activity, which means slow onset and longer duration of activity of fall in the blood pressure or maintenance of the blood pressure. So these are the unique features of amlodipine. Well, we'll go further ahead. This positive. So what is exactly happening in the sustained reservoir which I have spoken? Reservoir means a tank or a collection where you can store the things. So it is basically acting as a storage house. Your membrane is acting as a plasma membrane is acting as a storage house of amlodipine. So it is called as a reservoir. Sustained means there is always something present inside, so it maintains it throughout. So this positive charges leads to strong electrostatic interactions of amlodipine with the membrane phospholipid head groups. So there is an interaction between the amlodipine and your phospholipids, which means phosphorus and lipid head groups, which are present on your plasma membrane or on your cell membrane. So the amlodipine binds with the phospholipid head groups. So it is something like that amlodipine is there in your cell membrane. It is attached to the phospholipid head groups. These physiochemical interactions results in the drugs concentrating in the membrane at the levels more than 10,000 times higher than in the surrounding aqueous environment. So because of this interaction, the drug concentration in the membrane is approximately 10,000 times more than in the environment where it is, in the aqueous environment. At these high membrane concentration, there is a sustained reservoir of amlodipine available for binding over time to calcium channel receptors within the plasma membrane of the VSMCs. So now this is acting like a reservoir of amlodipine, or it is providing a reservoir for amlodipine. Well, these measurements explain the extended duration of action of amlodipine as compared to short-acting, less lipophilic agents. So these are the unique features of amlodipine when we are talking to the doctor. So we need to remember them. Probably the doctor is aware of it, but for your understanding, you need to learn them by heart. So now we go on to the next slide. Well, we are again talking about the higher vascular selectivity of amlodipine has 5 times weaker negative inotropic action on the heart as compared to nifedipine. Then there is low variability in tough to peak plasma concentration, so it maintains a homogeneity. There is low inter-subject variability. Well, different subjects won't have that, their effects might be different. Well, it is low. Then there is a round-the-clock blood pressure control. Reflex tachycardia, which we spoke about, is virtually absent and is present in your short-acting, non-selective dihydropyridine calcium channel blockers. So these are the unique features of amlodipine which we are supposed to know. Now moving on to the ancillary properties or the add-on properties or the other beneficial properties of amlodipine. Well, it has got an anti-anginal properties, it has got anti-atherosclerotic properties, it has got anti-platelet properties, and is used as an antioxidant. It is renoprotective, or it's safe for the kidneys, favorable effect on the lipid profile, and is one of the preferred choices in diabetic hypertensives. So these are the ancillary properties of amlodipine. So I'll repeat: anti-anginal, anti-atherosclerotic, anti-platelet, antioxidant, renoprotective, favorable effect on lipid profile, and is a preferred choice in diabetic hypertensive. So there are the 7 points which account for the ancillary properties of amlodipine. Well, now we talk about it in detail. Well, the therapeutic effects of dihydropyridine calcium channel blockers in treatment angina are due to reduced myocardial oxygen consumption by reducing the afterload, which we have already spoken. Then it improves the oxygen delivery to the ischemic myocardium by vasodilating the coronary artery. So it is allowing more blood to flow inside the coronary vessels. Various clinical trials have confirmed the anti-anginal effect of amlodipine. In a double-blind parallel group of study of amlodipine versus isosorbate mononitrate in the management of elderly patients with stable angina, once daily amlodipine provided significantly better control of stable angina than isosorbate mononitrate. Well, this was published in Cardiology in 2001. Well, these are the ancillary properties of amlodipine. We'll go further to the next slide. Well, now, as we have first was the anti-anginal effect, then we spoke about the anti-atherosclerotic effect. Well, this was again published in the Journal of Cardiovascular Pharmacology in 1999. Well, amlodipine may exert anti-atherosclerotic effects by the following mechanism. It inhibits smooth muscle cell proliferation and migration. It slows the platelet aggregation. It restructures the cholesterol-enriched cell membranes. Enhanced gene expression for low-density lipoprotein receptor proteins. Inhibition of growth factor release. Slowed calcium uptake. Restoration of endothelial-dependent relaxation. then reduction of adhesion molecules, expression in the endothelial cells, and the antioxidant effect.